testicular examination. So testicular examination, again, you have got again many scenarios. Let's do the examination part and then we will discuss those scenarios. That's the main thing. So first you have got the inspection. You'll see a mannequin is standing, half body mannequin. It's on the table. That's the main thing that you will see. You do the inspection. You will comment on the inspection of the testicles, on the penis, and in the groin area as well. So you do the proper inspection. Usually, when you are doing the testicular examination, what happens in the testicular examination? What happens is you always ask the patient to hold the penis. You always ask the patient to hold the penis. But in the exam, you will see in these OSCE exams, if the patient is there, patient is sitting on the corner. So you just have to verbally mention, ideally, I'll be telling the patient to hold the penis, but then you have to manage it on your own. Yeah. So inspection, you can mention, you have to comment on a lot of things. First of all, like in the breast examination, we can comment both the breasts are symmetrical, nipples at the same level, but you cannot comment the same thing here in the testicular examination because the testicles are not at the same level, right? So, but you can comment on a lot of other things. You can comment on if there is any redness, any swelling, any scar mark of any surgery, or any ulceration, any discharge from the penile penis, and normal scrotal rugosities, right? So all those things you can comment. Then it comes to the temperature. So in temperature, what you do, you compare the temperature of the testicles, you compare it with the thighs. You compare temperature of the testicles from the front side to the thighs. You compare temperature of the back of the testicle with the thighs as well. And if the mannequin has got the like foreskin, you will retract the foreskin as well. That's the thing. Yeah. Now, what else you have to do is after doing that, then in the examination, what are the things you need to check? You need to feel for spermatic cord. You need to feel for epididymis as well. Sometimes when you feel for epididymis, you might be able to feel a epididymal cyst as well. Epididymal cyst as well. There is a scenario on epididymal cyst as well. So feel for spermatic cord, feel for epididymal cyst if there is any. Right? Then what you're going to do, you're going to feel for the testicles. Feel for the testicles, see if it is soft, hard, and if there is any mass. If there is any mass, you comment over the mass in detail. Is it on the anterior side, on the back side? And if it is attached to underlying testicle to the overlying skin, and if it is painful, not painful, mobile, not mobile, is it soft, hard, is it regular, irregular? So you need to comment over the mass in detail if there is any. That's what you need to do. Also, you need to check one more thing. If there is a mass, if it is fluctuant or not. See, if it is fluid-filled cavity, they fluctuate. If it is hard swelling, that doesn't fluctuate. So that's very important. So it is not that the testicular masses can be done for any mass. For example, there is a small swelling. You're holding it with thumb and index finger. Fluctuant positive. What happened? You press it on one side, it will go to other side. This is fluctuation positive. That's the thing. Fluctuation positive. What about hard masses? So even when you're fluctuating, nothing is happening because it's hard swelling. So moral of the story, cystic fluid-filled cavity is gonna fluctuate. That's the main thing. So if you get a mass, you need to comment on everything. You need to comment whether it is fluctuant or not. Yeah. And later on, obviously, when you do the examination, you can also check if there is transillumination test positive or not. So they will be giving you a torch and a paper. You just fold the paper and shine the light from the back and check if it is transillumination positive or not. If you can see a red glow, meaning transillumination test is positive, it might be a case of like hydrocele. But sometimes fluid is there, but red glow is not there. So it might be pyocele, pus is there, it might be hematocele, blood is there. So that can be done. All right. All these things you can see in the examination video, everything is there. Now there are some spatial tests that you can do. Number one is Friend's test. Friend's test is very easy. You just elevate the testicles. If the pain is getting relieved, it is not testicular torsion. If the pain is getting relieved, it is not testicular torsion. Most probably it's a case of epididymal orchitis. Right. Number two, you have got another case that is cremasteric reflex. How you do the cremasteric reflex? Very easy. You stroke the medial aspect of the thigh of the patient. You can stroke it with the finger as well. You stroke the medial aspect of the thigh of the patient. If the testicles are rising, it's normal. That's normal cremasteric reflex. Okay. And this normal cremasteric reflex, the cremasteric reflex is lost in testicular torsion. The reflex is lost in testicular torsion. So that's your complete examination. Even varicocele is a palpable mass, feels like a bag of worm on the left side that you can see when you're doing the palpation. So what we're doing the inspection. When we're doing the palpation, comparing the temperature, and then in the palpation, what you're doing, you're feeling for spermatocord, epididymis, see if there is any epididymal cyst, then you feel for the testicles, see if there's any mass, comment over the mass in detail. Fine. Check the mass if it is fluctuant or not. Check the mass if it is transillumination positive or not. Then you have got two spatial tests, very easy, Friends and cremasteric reflex. Lift the testicle, see if the pain is getting relieved or not. If yes, it's not torsion. It may be epididymal. You stroke the medial aspect of the thigh of the patient. What you check? The testicles rising, that's normal cremasteric reflex. It is lost in testicular torsion. That's it. Cough impulse also can be done, but it's a whole mannequin. Like the breast mannequin, somebody is wearing that mannequin, but nobody is wearing the testicular mannequin, the whole mannequin itself. So verbally, you can mention, like, I'll ask the patient to cough as well, just to check cough impulse. That's something that you can see. So this is your whole testicular examination. That's it. Yeah. Have a look at this as well, hernia. You might get a teaching station on it. Sometimes there's a teaching station that comes as like your student has missed the classes for inguinoscrotal examination. So in that also you can go and teach them scrotum or testicular examination. And if you've got time, you can teach them about the direct, indirect hernia as well. Mainly you need to tell them these points actually. That's the main thing. Yeah. Okay, so let's have a look at this as well, and then I'll discuss the scenario, then I'll make your life, make it easy, like how much examination you can do and what you can skip as well. All right, so first of all, we need to know these main points. What is mid-inguinal point and what is midpoint of inguinal ligament, right? That's the main thing. So mid-inguinal point is halfway between ASIS and pubic symphysis, whereas midpoint of inguinal ligament is between ASIS and pubic tubercle. So it's pubic symphysis, this is pubic tubercle. Now, we need to know about the deep ring and we need to know about the superficial ring. Because what happened is the indirect hernia is actually coming from this inguinal canal. It's coming from the inguinal canal. Whereas the direct hernia is coming directly from the abdominal wall. That's the main thing, right? So, there is a thing I actually read in one of the books. They say indirect hernia is like a path traveler. It's traveling through this inguinal canal. This direct hernia, it's actually breaking through the wall. Directly through, there's a weakness, it will come through that weakness only, right? So that's the main thing. So where is this deep ring? Deep ring is found above. So you need to know mainly this second point, midpoint of inguinal ligament. Where it is halfway between ASIS and pubic tubercle. So where is this deep ring? Where is this deep ring? Deep ring is found above the midpoint of inguinal ligament. Whereas the superficial is found where? Superior to the pubic tubercle. That's the thing that we need to know. Now, the thing is, what happens is when you're teaching inguinoscrotal examination, there is nothing to teach in terms of direct, indirect hernia. You just need to teach these points. What is mid-inguinal point, which is halfway between ASIS and pubic symphysis, right? The mannequin is there, the testicular mannequin, you can maybe teach on that. Sometime, if they give you pen and paper, you can actually explain this on a piece of paper as well. Yeah. Main thing what we need to know is the midpoint of inguinal ligament. Where it is between ASIS and pubic tubercle. Then we need to know what is deep ring. Deep ring is above the midpoint of inguinal ligament. Whereas superficial ring, it is just superior to the pubic tubercle. That's it. So indirect hernia. So what we can do, it's coming through the inguinal canal. It's coming through the inguinal canal. And usually you will see it might be there in young patients. It's there in young patients. Direct, you might see in the elder patients and all, they are weakening in the abdominal wall and all, and that's how it is. And maybe you'll see indirect hernia, you will see the swelling. When they cough, the swelling might be coming in the scrotum as well. It may not be there in the direct. Right? Again, you don't need to go into that much of detailing. You just need to give them these landmarks. That's the thing. Inguino-scrotal examination teaching. You can start with the testicular examination, then teach this, or you start teaching this and then teach testicular examination. And the best thing would be ask the student, what do you want me to start with? Do you want me to start with these landmark first, or do you want me to start with the testicular examination first? That's how it is done. All right. So this is a testicular examination. This is your inguinal area landmarks. If you have to explain it to your student, what kind of scenarios that can come? Let's have a look. You're after the GP. Patient is 22, has made an urgent appointment to see you. Talk to the patient and examination and address the concern. Now the patient said, doctor, I noticed a mass in the testicle. Okay, I noticed a mass. When did he notice? I noticed yesterday. Okay, I booked an urgent appointment. Okay, and elaborate the mass, how big it is. Is it painful or not painful? Is it mobile or not mobile? Is it one mass, two masses, left testicle, right testicle, what about left testicle? So what you do the full elaboration of the mass. Yeah. What else I should be asking now? I have done the elaboration of the mass. Then my question would be anything else? Nothing else, doctor. Now, patient is 22. Patient has got a mass on the testicle. Should I ask cancer question? I would say yes, because you will see the testicular cancers are more common in young patients, and unlike the breast masses, testicular masses are mostly malignant as well. So you need to ask question. You can ask all those like weight loss, loss of appetite, and lumps and bumps anywhere else. Yeah. And maybe one or two anemia questions also we can ask, right? What else I should be asking? Ask if there is any fever, just to see if there is an infection. Maybe one or two questions for UTI. Maybe sexual history might be important as well in these cases. That's really important. Yeah. But when there is no fever, then there is, I think, no UTI as well. Yeah. So these are the questions that quickly you can ask, right? And then maybe we can ask any surgical history as well. You know, sometimes what happened, patient might have had a surgery for undescended testes, and that might be feeling like a mass. So maybe we can ask that as well, right? And the family history, do you think it is important? I would say yes, it is important as well. So ask that as well. Now, should I ask smoking, alcohol? Come on, I mean, you can skip it as well, right? Now, a lot of people will say smoking is a risk factor. Of course it is. Smoking is a risk factor for everything. Yeah, but if you see you don't have enough time, please start the examination management as well. Yeah. Now, so this patient, for example, after taking this history, patient just said, I've got a mass. So when you do the examination, so let's see which examination I should be doing. So I'll go with first inspection. I found nothing. Then I went for palpation. So I found a mass on the anterior side of this testicle, which is 1 into 1 centimeter. It is firm in consistency. It is regular. It is attached to the underlying testicle, not to the overlying skin. It is not painful and not mobile as well. And it is not fluctuant. So this is what you got, right? All right, okay. And now what happened is, are we going to do spatial test here? Because are we going to do everything? Not really. We'll be doing only a part of it. So when you do the examination, now, for example, Friends test, am I going to do it or not? Friend's test is you lift the testicle and the pain is getting relieved. If the pain is getting relieved, it's not testicular torsion. But in this case, what's the presenting complaint mass? And when I asked, do you have any pain? Patient said, no, there is no pain. So is there any point of doing Friend's test? You don't have to do. What about cremasteric reflex? Cremasteric reflex. Why we do cremasteric reflex? You stroke the middle aspect of the thigh of the patient, the testicle will rise. And if it is not rising, it means it's testicular torsion. It's lost in testicular torsion. Are we looking for testicular torsion in this particular scenario? The answer is no. So how much examination you're doing? You're doing just the inspection and the palpation. That's it. That's the only thing. So history will take 3 minutes of your time. Examination will take another 2-3 minutes of your time. You don't have to do any special test in this particular scenario, right? What's the management? Do a nice ice, obviously. And as I said, any mass anywhere in the body, patient will be concerned about cancer. So what do you think? He's 22. Is there any possibility of cancer? Yes, of course. So what we're going to do, maybe you can do the routine blood test here if needed in the GP itself. You can do urine test as well, right? And then what's going to happen? We have to make an urgent referral to the specialist within 2 weeks' time. That's the main thing. The specialist will be seeing this patient and the further investigations will be done. Now, which further investigation usually be done? We usually be doing an ultrasound scan. We will be doing tumor markers as well. Guys, just be very careful. Do not mention about the biopsy. We never do the biopsy. Biopsy will be excisional biopsy. Once you have confirmed it's cancer, you just remove the testicle. That's what we do. Otherwise, you do ultrasound and you do the tumor markers. If you find the tumor markers are high, what we do a CT scan as well to confirm the extent of the cancer. And what the treatment is, a surgery, you remove the testicle. That's how it is done. All right, that's the main thing. Again, you don't need to go into too much of detailing of these things because you won't have that much of time as well. So in the management, tell the patient we are suspecting cancer by doing a very good ice. Tell them a blood test, urine test we can do here, and the specialist will do further investigation like ultrasound and spatial blood tests like the tumor markers they can do, and then only we'll be deciding what exactly is happening, right? So that's how you can go about it. Yeah. Let's have a look at another one. After the GP, 22-year-old has got some discomfort in the private area. Discomfort. Okay. So, discomfort. Tell me more. So, doctor, I feel a bit heavy on the left or right side of the testicle. Okay. Any pain? No. Do you feel like there is a mass? Sometimes patient says yes. Elaborate that if there is a mass, right? Pain is not there. Ask about fever if it is there or not. There is no fever. Ask about any UTI symptoms the patient has got. Ask about any sexual history if there is something that you can get from there. Ask about if there is any family history positive for anything, right? Ask about any surgical history patient has got. All those questions you can ask. Fine. Nothing is positive. It's just discomfort this patient is having. Okay, let's do the examination. So when I started doing the examination, I'll do the inspection, that's fine. Then I'll go for palpation. What I found, I could find a epididymal cyst. It is not attached to the testicle. It was there at the back, behind, upper side, behind the testicle. Feels like another testicle. 1, 2, and third testicle. It feels like that. So that's what is your epididymal cyst. If there is any doubt, you can actually refer the patient for an ultrasound scan as well. That's the main thing. So you done inspection, you did the palpation as well. During the palpation, you found the epididymal cyst. Right, you can check it as well, whether it is fluctuant or not. That's something that we can check. Now, are we gonna do spatial test here, friends? Cremasteric reflex. Are we gonna do these tests or not? The answer is no. There is no pain. So what are you gonna achieve with these tests? You don't have to do just the inspection and palpation. What you'll be able to find, epididymal cyst. What is the management? What is the management? To be honest, there is no management. Let it be there. It's gonna be okay in a few days, weeks time. However, if it is causing symptoms to the patient is feeling too much of discomfort and all, then what can be done? We can first arrange an ultrasound and then we can drain the fluid as well. That's something that can be done, right? But again, think twice, 3 times, is it epididymal cyst or if it is testicular mass. In the testicular mass, you don't even take the biopsy because it can create the more problem, right? But if it is epididymal cyst, obviously you have to drain it, right? Any doubt? Any doubt? Please get an ultrasound scan, right? Are we doing any spatial test? Not really. Can I do it in 8 minutes? Of course, why not? So that is how it is done. Yeah. Have a look at another one. You're after in the GP, patient is 22, has got pain in the testicle. All right, pain, let's elaborate. So when we have got pain, what I'm gonna do? I'm gonna do the Socrates. Pain is there, there are a couple of stations there. Pain is there from last 2 days. Pain is there from last 2 days, and if you ask me how much, it's 5 out of 10. And if you ask me, it's a dull pain, right? And there is no radiation. Fine, do full Socrates. Then obviously I'm going to ask an open question if there is anything else. No, no. Now pain is there, so I will be ruling out lots of things there, right? Pain is 5 out of 10, dull pain 2 days. Do you think it is testicular torsion? Do you think it's testicular torsion? I would say not really, because the pain is going to be too severe, and I don't think so. My patient is going to wait for 2 days. Patient is going to jump. Patient is going to come to the hospital A&E straight away, right? But okay, then what it could be? So I'll ask it could be something related to infection, epididymal, mumps orchitis. So let's see if there is any fever or not. Sometimes patient says yes to fever. Then you need to go for UTI questions as well. You need to go for sexual history as well. That's the main thing. So sometimes this patient has got multiple sexual partner, right? So it could be a case of epididymal orchitis, right? Another thing, sometimes this patient is not having multiple sexual partner. Interesting history. But this patient tells you, doctor, I had a swelling here a few days ago, but that swelling is fine now, but I've got pain in my testicles. So it could be a station of mumps orchitis as well. So the pain, when the patient is presenting with the pain in the testicle, which is 5 out of 10 dull, no radiation, 1-2 days, think for these two differentials, right? Again, if there is a sexual history positive, multiple sexual partner, not protected sex, maybe going more towards epididymal orchitis, but if it is swelling here and then pain in the testicles, going more towards mumps orchitis. Okay, so what we're doing, pain, elaboration, anything else? No, testicular torsion, doesn't look like fever, UTI, sexual history, this is what you're gonna do. Now, when it comes to the examination, am I gonna do inspection? Of course. Am I gonna do palpation? Yes. So when you do the palpation, patient has got tenderness. Patient has got tenderness throughout the examination, right? So, and is there any mass? There is no mass, but patient has got generalized tenderness in the palpation. Fine. Now, the spatial test. Am I gonna do the Friends test? Yeah, I think I can do, because lifting the testicle, let's see the pain is getting relieved. If yes, it's not testicular torsion, it could be epididymal orchitis or bursitis. So maybe you can do that. What about your cremasteric reflex? I think it's not required because cremasteric reflex is lost in testicular torsion. Are you looking for testicular torsion in this particular case with this history that I've given? I don't think so. So you can miss that as well. So what we did inspection, we did palpation, and maybe Friends test, and that is enough, right? In terms of examination, what you can do, so in terms of investigation, we can do routine blood test. The patient has got any discharge, you can take the sample as well. That's the main thing. Definitely you'll be doing urine test as well. Yeah. If it is mumps orchitis, patient has got swelling here, now the pain in the testicles. So it could be mumps orchitis, as we said. So patient might be giving the history, I didn't take MMR vaccine. So that's the station is going towards that. He didn't take MMR because he might be having a myth in his mind thinking that mumps, this MMR can cause autism. It can cause enterocolitis. So there was a study which was done on 12 patients, which proved there was a relationship between MMR and autism, MMR and enterocolitis. But the study was done only with 12 patients. And then there were a lot of big studies were done which discredited this old study, and you can say now there is no relationship between autism and MMR. There is no relationship between MMR and enterocolitis. Okay. So what's the treatment for mumps orchitis? To be honest, nothing you have to do. It's going to subside on its own. Tell the patient to take rest. Tell the patient to take painkillers maybe. And that's it. It's going to subside on its own because it's a viral illness. You're not supposed to give anything to this patient, right? Supportive underwear they can wear. That would be quite helpful. That's it. That's it. Yeah. Patient might ask you a question in mumps orchitis. Doctor, I've heard it causes infertility. Is that true? The thing is one of the complication, but it's not very common. It's rare. Just continue with the treatment that we have mentioned. So it should be fine. Right. Another thing is the mumps. So you can report it as well. It's a notifiable disease. Another thing, once the infection subsides, you can encourage the patient to go for vaccination as well. That's what you can do. Again, I know I have given you lots of things in the management. You may not have enough time to that. So main thing is giving the diagnosis, giving the management, painkillers, and it's going to subside on its own. And the main important thing is addressing the patient's concern. Let's see what is his concern. And if it is epididymal orchitis, I mean, patient is having discharge and all, you can investigate. Patient has got multiple sexual partner, so you can investigate and then treat the patient accordingly by giving antibiotics and all. And if it is epididymal orchitis, you need to find the partner and you need to treat the partner as well. Otherwise, it's not going to make sense. The patient can get the infections again and again and again. Right, so that's what you have to do. So these are the 4 or 5 scenarios. We have got mumps orchitis, epididymal orchitis secondary to multiple sexual partners. We have got epididymal cyst. We have got the cancer one, and it can come as a teaching of inguinal examination as well. All right, so that's your testicular examination.